أروى.
هلا يا بروف، كيف؟ تمام؟ الصورة واضحة والصوت
الصورة واضحة؟
والصوت واضح.
خلاص. أنت محمد جعفر ليه قال الصورة ما واضحة؟ قال غريبة شديدة ولا شنو؟
لكن رفع كم حلقة حسي في اليوتيوب. ما رسل لك
إيه.
اللينك؟
ما رسل، لكن صورة وصوت.
صورة وصوت.
لا خلاص تمام. خلاص يبقى تمام. نبدأ
اوكي.
هسه ولا شنو؟ فاضل دقيقة ولا شنو؟
فاضل دقيقتين.
أيوة شكرا. Bismillahirrahmanirrahim. Hello, everybody, and good morning. It's still morning in Dar es Salaam. And welcome to this lecture, yet another lecture on infectious and tropical diseases. Now we are getting into more infectious diseases as we have almost finished the classic tropical diseases. So when we come to the infectious, it's not only restricted to tropical areas, but it's worldwide. True, there is a lot of effort in developed countries that they control the infectious diseases, particularly virus. But viruses do not respect borders and they cross. The COVID-19 virus has been an example of how the world can come together in one epidemic. And HIV/AIDS is still, it's started in the developed countries and widespread. So nobody is immune from these viruses. True, there is more effort in some countries to control it. To the last lecture, to this lecture, we have to give highlights of the previous lecture and then continue on what we wanted to finish up with as far as this lecture is concerned. The topic was viral hepatitis, and we discussed the term, although jaundice or hepatitis can occur for different reasons, be the viral hepatitis, the viruses, and not only A to E, A, B, C, D, E, but also yellow fever, Epstein-Barr viruses, and in bacteria, leptospirosis and Coxiella burnetii. These are another causes of viruses, and obviously chemical hepatitis, what we call toxic hepatitis or drug-induced hepatitis. All these can cause hepatitis. The differential diagnosis is extremely important in this aspect because you may get the same picture, symptoms of hepatitis due to virus as when you have it for paracetamol overdose. So it is important. And I would like to remind you that jaundice is not a diagnosis, just like anemia. Anemia is not a diagnosis. If you say iron deficiency, anemia, then this is a diagnosis due to blood loss, for instance. Jaundice is even less of a diagnosis than anemia because jaundice is a physical sign. Its yellowness appears in the sclera when the bilirubin is above 3. So it is, if you tell me that this patient is jaundice, you told me nothing. But if you say this is patient who have acute hepatitis, probably due to viral, then I can listen to you. So it is important to look into. And jaundice, the cause of jaundice is so wide that you have to link it to the clinical picture. Okay, the jaundice, the hepatitis is could be due to viruses, and when you say viral hepatitis, is customarily it is A, B, C, D, E. Okay, and as I told you last time, hepatitis B was discovered by the antigen, hepatitis surface antigen in Aborigines in Australia, and it was in the 70s used to be called hepatitis Australian antigen when it was changed. Now we know all the antigens and antibodies which is produced by the B virus. Um, and then we had a presentation of hepatitis in the 70s, which we did not know because we knew A and we discovered B. Then we had a hepatitis which we could not link to either A or B, and it was called non-A, non-B hepatitis. Okay, till in the 80s, hepatitis C was discovered, and then later on more viruses has been discovered, and up to now we are getting a type of hepatitis, viral hepatitis, which is non-A to E, non-A to E. It is non-A, non-B, C, D, non-A to E, which is now is being given a G title or others. But I would like to open your mind that the science continues. Science continues and research builds evidence-based medicine. We always refer to research and depend on research to find the way out. Okay, hepatitis, apart from viruses, it can be due to drugs, notably paracetamol overdose, because this is damage the cells. And then we have hepatitis due to other drugs like rifampicin and isoniazid. These two drugs are obviously the tuberculous drugs, and they are reserved, almost reserved for tuberculosis being a killer. So they can cause hepatitis. Um, and other causes of hepatitis are toxins, okay? Other toxins, which is widespread in the air. So the insult to the liver can be either from outside or from inside. And this is the inside we refer to is autoimmune hepatitis. These are antibodies which are being directed against the human cell, the own human cells, which is can be joints or skin or whatever. But here, these are what we call autoimmune hepatitis. And it used to be called lipoid hepatitis from lupus erythematosus, lipoid hepatitis, because we knew that these are autoimmune disease. We couldn't call it anything, but now the International Society of Hepatitis, viral hepatitis, has called it autoimmune hepatitis. And these are uh, antibodies directed on its own one cell. And it has a very similar picture to start with, but the end result is bad. Okay, we talked about the liver, and the liver is being a respectable organ, 1.5 kilogram. It's overseas or superior to the stomach, and hides the kidney behind it. The left lobe is now being important. It is separated anatomically from the right lobe, and now lobectomy for transplant of the liver is being using that anatomical division. It has many lobules, thousands of lobules, small lobules, which with canals running in, which is the canalicular of the biliary system, and they all come together in the common bile duct. And the common bile duct opens in the duodenum with a sphincter called the sphincter of Odis. Oddi. Okay, so it's very well organized anatomically. It is supplied by two types of bloods. One oxygen rich, which is arterial hepatic, and then one nutrient rich, which is portal vein. So we have two systems: the portal vein system, very important, and then the systemic system, which is here is represented by the arterial, and then they all go into the portal system goes into the systemic circulation through the inferior vena cava, hepatic veins, and then into superior vena cava, and so on. So that is the anatomy, and I always say, unless you really perfect your anatomy and physiology and then pathology, you cannot learn medicine. It is important. These are subjects, hard as they are, but they are very necessary. And those who can retain their knowledge about physiology and anatomy at this stage of development in your semi-final and final years, then you will do very well. Okay, what are the functions of the liver, which will determine what are the symptoms if these functions are disturbed? Okay, we said that the liver is a gate, a safeguard gate for all the nutrients that comes from the intestine. So everything you think about, which you swallow, whatever it is, good or bad, has to go to the liver and dealt with. This is a big task, huge task. Let just think about what we eat every day, what we inhale every day from fumes, what comes into our skin and then passes in the bloodstream. All this has to come through the liver to be dealt with. So the liver should be respected. And then I will talk about how to respect the liver later. But so every drugs, every chemical, which we call xenobiotic, should go to the liver through the portal vein and then dealt with. I would outline the dealt with. Okay, so it transforms the nitrogenous products, which are toxin like ammonia, into amino acid, very useful. It can convert the drugs, it can convert the xenobiotics, the chemicals, into water soluble, because most of these foreign xenobiotics or chemicals or drugs are lipid soluble. And if you have a lipid soluble structure, it will never get excreted from the body. It has to be converted into water soluble. If you take the liver out of a mice or a rat, and then you inject a drug, very simple drug, then the drug will circulate for a long time, for the life of the rat, without being excreted. But if you supply the rat with the liver, then the liver can transform that chemical, that fat-soluble chemical, into a water-soluble chemical, which can be easily excreted either in the feces or in the kidneys. Low molecular weight will go into the kidneys to be excreted. High molecular weight will go into the bile and the feces. So that is one aspect. So if you have a disease like hepatitis, severe enough, or cirrhosis, then you will have an abnormal metabolism of drugs. That is important. And you may have a retention of drugs which may cause side effects. So the other aspect of what we call detoxicating, the liver is a detoxicating agent, true, because it toxicates most of the drugs that come into its way, but it didn't mean to be detoxicating because it's an organ which is supplied by enzymes, and these enzymes deal with whatever you give it. So it means to convert it into water soluble, whatever that water soluble. But admittedly, some of the drugs, when converted, they become more toxic. This is a rarity, or less than very 1% or so. So it's detoxicating, if you like the term, but generally, chemically, it just converts the chemical or the xenobiotic or the drug from being fat soluble to water soluble to be excreted. Okay, bile is formed, and this is the synthetic part. This is the manufacturing part of the liver. uh, Bile is very important for emulsification, solubilization of lipids, and leading to digestion of fat. It is very important. Bilirubin is normal. Every day we break the cells, RBCs, hemoglobin is released, bilirubin is formed, and this has to be dealt with. Bilirubin is a fat soluble component, has to be converted into water soluble to be excreted. If you accumulate fat soluble bilirubin, which comes from the RBCs as fat soluble, then we have the direct and indirect bilirubin, and the fat soluble will remain in the body for a very long time. And you remember, if you have very high bilirubin, which is fat soluble in children, or especially newborn, due to rhesus incompatibility, the bilirubin can deposit in the brain and giving you kernicterus. So it has to be dealt with by the liver, and the liver of the newborn is not mature enough to deal with that. This is why we help it with either ultraviolet light or by exchange transfusion. So the other important part, which is again appears in the diagnose in the investigations, is the synthetic ability of the liver. Okay, the synthetic ability of the liver. The liver produces almost all circulating proteins apart from gamma globulin, which is produced by the lymphocytes. Proteins, transferring proteins, or conjugating proteins with metals like transferrin with iron, ceruloplasmin with copper. All these are produced by the liver. Okay, and then it is important that the liver is also an active storage place. Active meaning, if you are inactive storage, if you are inactive storekeeper, all is being given to you, like chairs or paper or whatever, you label it and you put it there. Okay, when they need it, they trace it and take it out. So it is in that way. It is inactive for certain things like vitamin B12. We give the example. This is just kept there, but it is an active storekeeper, meaning that if you have a substance which is in over need of the body, then it converts it into a material which can be stored. This is the example of that is glucose. Glucose is being transported into glycogen. Not only that, but if you need glucose back, it can convert glycogen into glucose. Okay, that's glycogenesis. So it is that important in sense that the balance of everything is not only a storekeeper, but it balances and regulates the glucose level. Amino acids again is another thing, and the liver can even be cold to change amino acids into glucose if I have a severe glucose drop. So it is a very important item in our agenda. The people ask me about to elaborate on the how the liver is transfer the fat soluble to water soluble. That is another topic. But I would just like to remind you that there are microsomes. There are microsomes in the smooth endoplasmic reticulum of the hepatocyte. These microsomes contain microsomal enzymes. And these enzymes are of two types, type A, which is oxygenation or hydration, adding OH group, or adding an oxygen or adding hydrogen molecule to the compound and becomes more water soluble. Maybe it goes to stage 2 or phase 2, which is then conjugated by glucuronide transferase, adding sulfate or glucuronide. So it becomes more and more water soluble, depending on the stuff. The other question which arose is the capability of the liver to do well. If you can do well, you can take the stress, you can expand yourself, you can get more power when you need it, and you can be more able. And the liver is that person. The liver can enlarge in itself, can regenerate its cells, okay, and it can activate its enzymes. This is how the liver can cope with extra duties. The normal duties, if you eat a normal things, but if you have a toxin, then the liver will be activated, and the activation of the enzymes of the liver is called enzyme induction. Enzyme induction. That is to say that the enzymes are being more active, like they are being given more power, more fuel, and then instead of converting the drug in 2 hours, they convert it into 1 hour, and this is enzyme induction. And in matter of fact, the liver can enlarge in size. Can enlarge in size. Okay, we have shown it before that the liver size using ultrasound can enlarge in certain conditions and shrink in other conditions. Old people, geriatric people, the liver can be smaller. And not even that, but even the capacity of the enzymes can be less. Okay, children are smaller and then less enzymes. Racial and environmental factors will determine the activity of the enzymes. People who are not exposed to chronic enzyme inducers are, has dormant enzymes. We did a study before, studying liver enzymes in European, in Britain, and against Sudanese. We found that the British enzymes are faster, are activated, and this we thought is due to a lot of preservatives in the food they take. They take frozen food more often. Okay, the tests which we are going to use is, the enzymes are very important. Transferases, among transferase, which is AST, and alanine, which is ALT, AST and ALT. ALT is more specific to the damage of the cells. So, and then the alkaline phosphatases, which is secreted from the enzyme, which is secreted from the canalicular, and we have two alkaline phosphatases, the bony one and the liver one. These are, although are not function of the liver, but it's very useful. In one sense, acute hepatitis, then the enzymes will be high. The alkaline phosphatase will be just slightly raised, okay? Serum albumin will be just normal, or prothrombin will be normal. Why is that? Okay, acute is you release the enzymes, okay, because it damages the cells. All right, the canalicular is not affected. Glyphosate is not very much affected. The albumin and prothrombin are the two markers of synthesis, of manufacturing, okay? And they are not affected in acute stage. But when you have chronic hepatitis, you get more damage, and the albumin will be low and the prothrombin will be low. If you reach the stage of cirrhosis, then you had it, and the albumin and prothrombin will be low. So in acute stage, acute hepatitis, then the enzymes will be high, alkaline phosphatase will only be slightly raised, okay? But albumin and prothrombin will not be affected largely. But if you go to chronicity, then the synthetic ability of the liver will get reduced, and serum albumin will be low, and prothrombin will be low. So these are the important factors in diagnosis. Okay. As we said last time, the ultrasound has really changed our understanding of what liver disease is all about. So it's very, very useful. And now we are even measuring the elasticity of the tissue of the liver. Okay. Okay. Acute hepatitis is characterized by necrosis of the cells, laying of fibrous tissue, okay, and disturbance of liver function test of liver functions, mainly AST and ALT. Okay, but the necrosis of the liver and inflammation is the hallmark. Okay, so it is a clinical diagnosis in the sense, but then we can do serology. Serology for, if we think this is hepatitis A, we can do the serology, okay, immunoglobulins for hepatitis A, and hepatitis B, the surface antigen, the core antigen, C, then the core antibodies, not the antigen, because antigen of the C doesn't appear in the plasma. Okay, so the serology is important. In acute hepatitis, the AST, aminotransferase, is at least 10 times the normal. And this is a giveaway that it is the very high level of aminotransferase. Okay, so we said that viral hepatitis is commonly or agreeably linked to the viruses which are A, B, C, D, and E. A, B, C, D, and E. The A we have dealt with, and the E is very similar. It's a sister to the A, okay? All these viruses, A, B, C, D, and E, are RNA viruses except B. B is DNA virus. Okay, all are RNA viruses except B, which is DNA viruses. Okay, the A is in epidemic. It takes an epidemic, and E is also epidemic. And these A and E are highly contagious, meaning that if you live with somebody and his excreta is mixing with our food or drink, then the virus can go. This is why we fear an outbreak of hepatitis A in schools, because there the school children are very well mixed together and they can pick up the infection very easy. So it's highly contagious, okay, but self-limiting. Luckily, this is a fecal-oral infection, and causes severe hepatitis, but self-limiting. Usually there is no sequelae, no hepatitis or cirrhosis. Okay, A and E. What is the difference between A and E? We already dealt with the symptoms of hepatitis generally. These are, fever, abdominal pain, very severe loss of appetite. Abdominal pain might be in the side of the right hypochondrium, the liver, all right, but off food, you are off food, the stools may be pale, slightly pale. This is a stage of pre-ecteric, that is maybe called prodromal or pre-ecteric. But the difference between prodromal and pre-ecteric, the pre-ecteric is part of the disease. It goes into the part of the disease which is pre-ecteric and then ecteric. The prodromal is the symptoms which precedes even the pre-ecteric. Okay, these are the general symptoms, and by and large, these are the symptoms of acute hepatitis for any reason, B, C, autoimmune disease, whatever. Okay, so the A is luckily we can give immunoglobulin, all right, and there is a vaccination. Okay, E is restricted to a population of pregnant ladies and children, pregnant ladies and children. Okay, while A is widespread, E is restricted. And hepatitis on pregnant ladies is a fearful event. We really get scared when a pregnant lady gets hepatitis because for fear of going to fulminant hepatitis. And fulminant hepatitis is usually fatal. And fulminant meaning widespread, very severe, all the cells are affected, the liver will become smaller, bleeding will occur because of prothrombin and coagulation factor. Patients will be comatose and may fall into death. That is an important cause of maternal mortality. It is an important cause of maternal mortality. The A and E, the difference is E is usually contracted from contaminated water. And all of the epidemics, we recently have an epidemic in South Sudan. We had in Darfur. Then these are the very severe epidemics which occurred, unfortunately, and people, pregnant ladies, were markedly affected. Okay, the jaundice, once the jaundice appears, the prodromal symptoms, and then the pre-ecteric phase, which are mixed or overlap, then the jaundice appears. When the jaundice appears, well, the diagnosis will be easy. But at the time when the jaundice appears, the urine becomes dark, become red, and what we call a shy tagil. Okay, so it is then it becomes less and less, and the patient becomes better and better. All we can do is either give immunoglobulin or symptomatic treatment. Vaccine is very effective. There is a development of a vaccine. There is no vaccine as yet which has been tested beyond doubt. Okay, but there is a vaccine which is very effective and now vaccine of A is being included in the package of vaccination of children. Okay, our fear from acute hepatitis is twofold. One, going to chronicity. It may go to a chronic hepatitis, and we will deal with chronic hepatitis now. Or it can go to cirrhosis. And then if it goes to cirrhosis, then hepatocellular carcinoma. Because cirrhosis in itself, apart from being B or C, which are oncogenic, but it can lead to hepatocellular carcinoma. So this is our fear. Our fear is fulminant hepatic failure, okay, when the prognosis is very bad, especially if the prothrombin is prolonged. In the fulminant hepatic failure, you do the prothrombin. If it is very prolonged, then the prognosis is bad and the patient chances are not very, very severe, very, very good. And the second is chronic hepatitis, and later is cirrhosis of the liver, which we fear, and later is hepatocellular carcinoma. So that is about A, E, okay. We dealt with B last time, and just in summary, the B has a lot of markers, maybe sometimes confusing. But to summarize the markers is you have the S antigen, which is a surface antigen. And the surface antigen is what appears in the serum, okay? For instance, like E again, E, going back to E, E appears in the hepatocyte, okay? We have an anti-E, okay? For A, there is, you can link A with the presence of A in the serum. B is surface antigen which appears in the blood, and this is how it was first discovered in the Aborigines of Australia. Okay, so B is the surface antigen. B has a core because the core of the virus, the surface antigen is the surface, is out the envelope, which can be shed and go into the serum. But the core, the virion itself, which replicates, is called DANE antibody, DANE antigen. Okay, and this is the antigen which contains the nucleocapsid of the DNA. Okay, the double-stranded DNA of the bee, and then there is a shed, is a cleavage of an antigen called E. Okay, called E. So we have the S antigen, and the S antigen is a basis for diagnosis and basis for vaccine. The C or C antigen, we detect the C antigen by detecting the antibody. We cannot detect the C antigen. Okay? And then the E can be detected as antibody and has a significance. What are the significances of this? S is diagnosis and vaccine, okay, and chronicity. Chronicity. If you have an acute hepatitis due to B and 6 months elapses, then after 6 months, definitely the virus should be cleared. If it is not cleared and there is an S antigen after 6 months, then you are a carrier or you are in chronic hepatitis. So this is the importance of the S. Okay, the C we detected by antibody, anti-C, all right? And this is again will give, especially if it is an IgM type, antibody of IgM, meaning there is active infection. If it goes into IgG, okay, anti-C, then it becomes that you have passed the acute stage and now you are a recovery or immunity. Okay, the anti-S antigen is appears later and it indicates immunity. So if you have a hepatitis B infection, you will have all the antigens, but then some of them they disappear, okay, after 6 months. Some antibodies will be high to start with, like E antigen and C antigen antibodies, C antibodies and and E antibodies, but then later they become IgG type, not the IgM, which indicates acute infection. So these are the important things. It's always said that if you have the E antigen, okay, detected by the antibody, if you have it, then this is bad news. It tells that the hepatitis is severe and it is aggressive and it may lead to poor prognosis. Okay, so that is B, and there is a vaccine for B. If if you have an acute attack of hepatitis B and you want to help a patient, you can give immunoglobulins. Immunoglobulins can always be given to A, B during the acute stage when you are exposed. Okay, but later on, you need to develop your own immunity and by vaccination. Okay, so the C virus has very interesting, it's been discovered in the 80s, and it is seen in the Egyptians. There is a very high prevalence in Egypt. I don't know what is the situation now. There was President Sisi, I think, offered the treatment for C for free for a population, and I don't know what the impact that was. But anyway, C is being seen when it came, and there was a study in Saudi Arabia. They studied all those who are working in the hospitals, and when they drew the graph against ethnicity, against where they come from, they found a very high peak. And when they looked down into the country, it was Egypt. So from there, it was known that Egyptians harbor the sea 10 times more than other places. Okay, so this geographically, why is that? We don't know, but the theory is that for schistosomiasis treatment, used to give IM injection, and there the sterilization was not very high, and people used to have the big syringe with 20 or 30 mils, and each one will be 5 mils. They inject 5 mils, they take it to another one, 5 mils till it finishes in the 4 patients. So it is maybe that because we know that C is parenteral. C is parenteral, okay? And very little sexual, while B is equally sexual and parenteral. Okay, parenteral meaning any blood components, and sexual B is more in homosexual, and this is has to remember because heterosexual, you the vagina is epithelial cells. The in homosexual, the rectum or the colon is columnar. Columnar cells are weak. So if you ejaculate within in the intestine from the colon, then you may hit the columnar epithelium and cause ulcer. This is why hepatitis B is very high in homosexuals, and AIDS again is very high in homosexuals, maybe 100 times more than in heterosexual. Anyway, so BC is very less on sexual. It is mainly on parenteral. So the hepatitis C is an RNA virus. Okay, it is double envelope. It is double envelope. It is virus, virus. Okay, double shelled because this is again is important, and it is the center of it is antigen where the RNA replicate to produce small c. Okay, the mother to child, which is important in B, is also important in C, the transmission. What is the importance of mother to child? In B, it is usually the child will contract infection in the perinatal, okay? In the perinatal is during delivery and later perinatal, okay? Okay, C is again vertical, and the importance of the vertical transmission is that the disease becomes serious in the future. Okay, while adults, if they contract hepatitis B, they clear it, they can clear it. Large proportion, only 5% or 10% will remain chronic carrier. Here in children, up to 80%. If you contract it in the neonate, it becomes with you, and in the future, you become carrier, and up to 80%. This is why hepatocellular carcinoma is usually in areas where the vertical transmission is active. Okay, the how we detect the hepatitis C is hepatitis C RNA is made by anti-hepatitis C virus. Okay, antivirus. Okay, In the neonatal contraction, 30% will go into cirrhosis, and about 50% will develop chronic hepatitis. Will develop chronic hepatitis. Very serious. I think hepatitis C is not a welcoming virus. Okay, especially that there is no vaccine up to now. Okay, so hepatitis C is parenteral, and you have to be careful about not contracting hepatitis C. Okay, and if you ever contracted hepatitis C in an acute infection, then you can have an immunoglobulins. Okay, it will be a blessing if you have a vaccine. Okay, how would you treat acute hepatitis C? As we said earlier, the clinical pictures are the same, okay, or very similar. Okay, it is usually treated by pegylated interferon, pegylated interferon alpha, pegylated, P-E-G-Y-L-A-T-E-D, pegylated interferon interferon alpha, and ribavirin. Two are being given, okay, and especially in chronic hepatitis of the C, okay. But it is a nasty virus which the acute can proceed in 60% to chronic hepatitis, okay. And once you have C, chronic hepatitis, then you will have a high chance of hepatocellular carcinoma. I have a friend who has been treated, okay, with pegylated interferon ribavirin, but unfortunately he developed hepatocellular carcinoma after I think 7 years, and he passed. Okay, so that is hepatitis C. It is mainly parenteral, and one has to be very careful. The infection obviously is associated with use of syringes which are contaminated, particularly in addicts, Okay, the addicts obviously they use syringes, from one person to another. Why don't they use clean syringes? Because A, costing, B, they are so jittery that they wanted the drug, and they can take it without precautions. Okay, so anyway, it has a very high incidence of chronicity, going to chronicity, and have high incidence of going to hepatocellular carcinoma. C is usually parenteral, very much less asexual. Okay. We have then the Delta virus or D virus. D virus is an RNA, as we said, all of them except B are RNA. It's Delta virus, and it's an incomplete virus. Why? It has to have a hepatitis B cover, and hepatitis B parenthood. It is parented by hepatitis B being incomplete, and it doesn't exist by itself, so incomplete. So hepatitis B is not only in itself is harmful, but it can invite and harbor D virus. And hepatitis B is needed for replication of the E, okay? But ED virus, which is Delta, is common. It's common in many parts of the world, especially South Europe, Italy, Greece, Cyprus, but also in Central Africa. So what does it do? What does it pathologically do? It causes two types of infection. One is co-infection with hepatitis B. And sometimes super infection. So the super infection is easy to think of. is somebody who has a carrier state, then he can contract an E, okay, and then becomes having an acute hepatitis of the E type, but on top of the B. In co-infection, you have a hepatitis B infection with E, okay? So the two working together, okay? The two are working together. And then very difficult to differentiate between what B did and what E did, okay? But we think that if you have a B hepatitis and also a D hepatitis, which is the delta hepatitis, then you will get a biphasic jaundice, biphasic stage of rise of transaminases. Okay, so this is the co-infection of D delta with B. So you'll have an infection of B giving you hepatitis. The D is just tagged there, and then once the infection of B is lessening, the D will give a new infection. This is what we call co-infection. Otherwise, the superinfection is the one which will be on top of the presence of hepatitis B. Okay, okay. These are the viruses, and summary: we will be lucky to have a vaccine. We are lucky to have a vaccine against A and B. Okay, immunoglobulins can be used all over for all infections if you have an acute stage of the hepatitis. And E is the vaccine is in development. Okay, once you have a vaccine, we are rest assured. Okay, vaccines are blessing. It's a blessing. It's a God blessing. With the COVID, what stopped it is not the contributed to by care and mask and whatever, but once the vaccine came, everything settled. So the vaccine will be the blessing for the state of viruses. Okay, then we have the chronic hepatitis. Chronic hepatitis. And from chronic hepatitis, you may mean that you will have a symptom of hepatitis but with chronicity. And the chronicity here may be active, then becomes chronic, or may be asymptomatic, but the liver is chronically inflamed, okay, or exacerbation of peaks of acute disease, acute hepatitis on the chronicity. So it is maybe the sequel of acute hepatitis for whatever reason, or maybe there even without acute hepatitis showing itself. Okay. The common clinical picture is the same. The common clinical picture is the same. But it is important histologically that to demonstrate that there is a chronic inflammation, chronic necrosis with chronic inflammation. The symptoms may be asymptomatic or fatigue and sleep disturbance. Okay, these are these main symptoms, but as you know, these are the vague symptoms. Okay, may be discovered by the routine examination of blood. You must just send the blood for the lab, and then suddenly you will get a disturbance of aminotransferase ALT, and now we are going from the chronic, from the acute phase where there is albumin is usually reserved and prothrombin into an affection of albumin and prothrombin. So these are the ones. Okay, chronic hepatitis can occur with all viruses, okay, B and C, notoriously. As we said, A and E do not go into chronic phase. only the B and C will go into chronic phase, chronic hepatitis. But other reasons can occur, like metabolic reasons, like Wilson's disease. Wilson's disease is related to copper metabolism. There is an amino acid called, or a protein called ceruloplasmin, which is produced by the liver, which is a carrier of copper. So if you don't have ceruloplasmin, you get copper deposited, and this can cause chronic hepatitis. Drugs can go into chronic hepatitis. We already dealt with them. And then steatohepatitis. Steato meaning fat, fatty liver. Fatty liver. We used to think that fatty liver is just something we noted in ultrasound, but now it is clear that steatohepatitis can occur. Okay. Here the AST and ALT is up to 5 times the normal, but the alkaline phosphatase, okay, and gamma glutamine transferase, okay, is slightly raised. AST, ALT 5 times, alkaline phosphatase is just raised, while albumin and prothrombin normal, still normal, unless it goes into cirrhosis. So this is a stage between the acute hepatitis and the definitive cirrhosis, between the two stages. Okay. In histology, it is very important to demonstrate hepatocellular necrosis and chronic inflammation. And there is cellular infiltration in the portal areas. Okay. Okay. The necrosis is dotted necrosis, spread all over, but very heavy around the periphery. This has the special name of piecemeal necrosis. Piecemeal necrosis. Okay? Piecemeal necrosis. Okay. Chronic hepatitis now is reversible. We used to say that if there is fibrosis and it is not reversible, this is not true. Chronic hepatitis can be reversed by drugs, and chronic hepatitis due to even to autoimmune disease can be reversed by drugs. Okay, so don't give up with the with treatment. So you have to pursue treatment very diligently. Okay. Then I think we have about 5 minutes or so. I would like to touch on autoimmune hepatitis. Autoimmune hepatitis, which I said earlier, it used to be called lipoid hepatitis. Lipoid hepatitis. It's no longer called lipoid hepatitis because the autoimmune hepatitis international group insisted that it will be called autoimmune hepatitis. Okay, it is a chronic inflammation like the others. Okay, and that is by pathology or by histopathology, liver biopsy. You have to have autoantibodies, and these are the early cells and rheumatoid factor and all the rest of it, and then high level of immunoglobulins. Chronic inflammation by histopathology, the autoantibodies, and then the high level of serum immunoglobulins. It is largely a disease of women. Autoimmune hepatitis is largely a disease of women. It is one of the 3 major autoimmune diseases of the liver. There are 3 major. The autoimmune hepatitis, we have the primary biliary cirrhosis and primary sclerosing cholangitis. Okay, say that again. The autoimmune liver disease, autoimmune hepatitis. The other one is primary biliary cirrhosis, and then primary sclerosing cholangitis. These are the 3. The primary biliary cirrhosis and primary sclerosing are obstructive. The symptoms are very clear from the start. This is an obstructive jaundice. And here you will have very high jaundice with greenish yellowish sclera. You will have high alkaline phosphatase, itching, and all the rest of it, very pale stools, dark urine, as in any other cause of obstructive jaundice. But the autoimmune liver disease is not obstructive, okay? It is usually just the symptoms of hepatitis, maybe the symptoms of chronicity is absent. When I talked about chronic liver disease is almost by definition cirrhosis of the liver. And these will show themselves, cirrhosis will show themselves with the classical physical signs. Just to remind you of it, you may get jaundice, you may not get jaundice, because you have a decompensated and compensated cirrhosis, but you will have maybe gynecomastia, you will have spider nevi, you may have palmar erythema, okay? And if you are alcoholic, you will get dupuytrenine contraction, okay? And then liver may be either small, shrunken, hard, large, and firm, and splenomegaly due to portal hypertension and ascites. Okay, you will have bleeding tendencies because of the low thrombin. These are the stigma of cirrhosis. Say that again. Jaundice may be there. Okay, spider nevi, gynecomastia, palmar erythema, and the dipyridine contraction in patients who are alcoholic. All right, and then you may get bruises and bleeding from the skin. Okay, the progress is, has a chance to go into chronicity and cirrhosis of the liver. All right. The onset usually either in young adults, 15 to 25, or another peak from 45 to 60, okay? And then the IgG is very high. Okay, autoimmune hepatitis will respond to corticosteroids. To the extent that if you give corticosteroids and you don't get a response, then doubt the diagnosis. It has to respond very quickly to corticosteroids. As to the future is something which you need to titrate. If there is poor response or not very acceptable response to corticosteroids, you can use azathioprine, which is an immunosuppressive. A-Z-E-T-H, azathioprine, I-O-P-R-I-N-E, azathioprine. Okay. So these are the, and these patients should be followed for life. These patients should be followed by life. But they can, if you are diligent, you can give them enough dose of this and then follow them up and beware of the fact that they may go into the slip into cirrhosis of the liver and get later hepatocellular carcinoma. Okay, I said acute hepatitis, we fear acute fulminant hepatitis or acute fulminant liver disease, and this is serious. It is a state of damage, necrosis, massive damage to the hepatocytes. It is causing very severe jaundice. The patient will be ill. All these nitrogenous products, ammonia, which used to be filtered by the liver, are now passing through the liver into the brain, causing encephalopathy. So disturbance of consciousness and encephalopathy is a major presentation of fulminant hepatic failure, and it's usually fatal. The patient will be ill, hypotensive, hypoglycemic, drowsy, comatose, and unfortunately succumb to the hepatic failure. Succumb to hepatic failure. So it is something which we need to avoid, not to treat. And avoid acute hepatic, fulminant hepatic failure or liver failure. Okay, and then obviously when you reach the stage of cirrhosis, then that is another discipline, another talk, because from there we used to say uh, cirrhosis is conservative. Nowadays we can transplant the liver, and this has made a lot of big revolution on our understanding and our treatment of uh, liver disease. I'd like to recommend liver disease, hepatic liver disease by Sheila Sherlock. Sheila Sherlock, the late Sheila Sherlock, she's a dame, and dame is, like the Queen, now the King of Britain. They give an honorary degree, which is the highest is Sir. You give Sir because you have been distinguished in somewhere. Okay, and the ladies are given Dame. So she was Dame Sheila Sherlock. She wrote a book about liver disease, and for years this book was, as Professor Reed, who mentored me, used to call it the Bible of liver disease. I recommend, if you catch it, if you see it, you go through it. It needs to be, I don't know if there is new editions of it, but it is a very important book. And liver disease is about gastroenterologists or either gastroenterologist of the central part, okay, or the hepatologist, okay. You can concentrate on one of the others, but hepatology is a complete discipline which needs to be studied, and doctors, students get more interested in liver disease. With that, I conclude today's lecture. I'd like to thank you very much for being with me in this lecture, and hopefully we'll see you next Sunday. Thank you. Bye.